Hello, everyone. Welcome to our webinar discussing men's health, hosted by the Texas Oncology Foundation and our presenting sponsor, Texas Oncology. I'm Tamika Felder. I am a 21-year cervical cancer survivor, and I am so excited to be joining you today. And we know that all of our topics are really important, but this is a discussion we know that needs to be had. So I really want to just thank all of you for participating today. We're going to let the audience build up a little bit, but while you're waiting, I want to share a little bit of some housekeeping rules. And if you're watching this on the replay, don't worry, you're just here with us too. I want you to respond and tell us what you thought about this, share it with others, have a discussion with other men in your life, and make sure they know this great information that we're sharing today. For you who are here with us live, I want you to share a little bit about yourself in the chat. And here's what you need to know. You can see and hear us. We can't see and hear you, but we'll be monitoring the chat, and it's super important for you to be involved in the discussion. So that means taking those fingers and typing away and being engaged in this, okay? We want to hear from you. Let us know where you're joining from. Let us know if you're a cancer survivor, what type of cancer you had. Are you a caregiver? Are you here because you want to learn more to help the men in your life? Whatever the reason is, share a little something about yourself today. So I want to continue to recognize our generous supporters, Survive and Thrive. I have my cup today. This was on accident, but it is one of my favorites because as a 21-year cancer survivor, you know, I want to remember that life isn't just about surviving the cancer, it's about thriving it. I want to thank each and every one of you who are joining us today and showing up. We know that we're in this virtual space and everyone's a little bit zoomed out, but it's okay. We have a really good, engaging conversation for you. Thanks for all the partnership and continuing to enjoy these conversations. I want to talk a little bit about the Texas Oncology Foundation, which is near and dear to my heart. If you've heard me share before, you know it's no secrets that I think it's just one of the best programs out there for cancer patients and thrivers, because there's so many opportunities for us to have conversations, not only about the actual diagnosis of cancer, but also the social and emotional side effect of cancer, because we know you can go through a cancer diagnosis, but cancer leaves the breadcrumbs of all the emotional things that linger behind it. So it's really important for us to be a community and stay with us together. And if you were a part of our virtual camp, let me know, because it's nice to see you again here for that. Kelly Condon, who's already posted in the chat, will be there happily gathering your questions and your thoughts, because sometimes it's not about having a question. Maybe you heard something that you agree with, or you know a little bit more of. We all learn from each other. You know, it's been 21 years since I went through cancer treatment, so I'm always amazed at the medical advancements and developments that are happening. And there's no better expert at cancer care than those of us who've gone through it. Just share your experience. I'm excited to introduce the panelists today. We've had a quick chat, and if you logged in, you saw we were already jumping into it. So it's exciting to have them all with us. We're going to start with Dr. Shivnani and then go over to John Griffin. They're going to introduce themselves, and I'm also going to ask them a little icebreaker question. After they introduce themselves, I want them to share that if they could do anything in the world outside of the wonderful work that they're already doing, what would it be?
That's a tough one. So thank you, Tamika. My name's Anand Shivnani. I'm a radiation oncologist, and my role at Texas Oncology is in the care of cancer patients and using radiation to treat patients with cancer. This means I work closely with surgeons and medical oncologists to design treatment plans and execute them for patients suffering with cancer. And I think I would probably want to travel the world if I wasn't doing what I was doing. Thanks for having me.
Thank you for being here.
You ready for me?
Ready?
My name's John Griffith, prostate cancer survivor, and that had very little to do with me and a whole lot to do with a bunch of other people, including Dr. Shivnani, but family, many other doctors along the way. The reason why I'm here today is because that very line there, men just don't, engage themselves in their healthcare too much, and I feel extremely lucky to be alive.
I think a lot of people really do feel that way. When you first hear those words, "you have cancer," it's a lot to unpack, and you definitely feel the weight not only of just the world, but your own mortality. And so it's really hard. What was it for you when you first heard those words, "you have cancer"?
You know what? First of all, I forgot to tell you what I would do.
Oh, yeah.
Yeah, I think I would be a rock star. I'm a musician already. Kind of abandoned it a little, pursuing it heavily professionally. Kids came along, but I'd be a rock star. That'd be fun.
I love it.
So your other question was about
When you heard those words, "you have cancer," what were your first thoughts?
I just thought it was talking to somebody else. It was really, and I use this expression a lot. It was literally like looking in a mirror and not knowing the person looking back at you. It's just like, this is not me. This is a dream, or this is something else, but it's not me. And it took me several weeks to finally accept it.
And, for me, what I learned 13 years later, right? You think that you're diagnosed with cancer, you're no evidence of disease, you're done with treatment, and life just picks up right where you left it off. And I had a rude awakening that was not the experience. And for me, it very much was, once you accept what has happened to you, you can truly move forward, which
Yeah.
again, is why I love conversations like this to discuss those aspects of cancer.
That's a powerful moment when you finally accept it. That's power. Prior to that moment, it's like you have no control over anything. But when you finally do that, you get some power back.
Dr. Shivani, we're here to talk about cancers that affect men, and we know that men sometimes drag their feet if they're not just cemented and not going to get checked, not being proactive with their health, going when they're wrong. I just had this thing happen with my husband just the other day where he didn't want to go to the doctor because he knew he wasn't doing what he was supposed to do, and I had to push him to go, which we had a little spat about it, but in the end, he knew it was the right thing to do. But we hear so much about awareness for cancers that may affect both genders or women. We may not know as much about cancer types that largely affect men. Can you talk a little bit about those and what signs and symptoms we should be looking for?
Yeah, so the main male cancer that we think about with screening is prostate cancer. And so typically, if men are engaged with their primary care physician, they should be having these discussions with them. And typically, we recommend starting screening with a blood test called the PSA at the age of 45. In some groups, African Americans, men with family history, we start at the age of 40. And we typically continue that till the age of 75. And then after the age of 75, it's really sort of a one-on-one discussion with each patient. And in general, we know that when we detect cancer earlier, there are more treatment options available, outcomes tend to be better, treatment tends to be less invasive. And so that's the main male cancer that we think about. But there are cancers that affect both men and women, where we do see men tend to undergo screening less often. Colon cancer is a good example of that. And so similarly, at the age of 45 now, men are recommended to have a colonoscopy or some other form of colon cancer screening.
You mentioned PSA. Could you share more about what that is and what could cause a spike, in a PSA, for example, from 7 to 22?
Yeah. So I think There's lots of things that could cause the PSA to increase. It is a blood test. It was discovered about 40 years ago, and it's a sort of an initial screening test for prostate cancer. But there are plenty of other things that can cause the PSA to increase. It can change with age. It can change with infections of the prostate or near the prostate. It can change if you check it right after intercourse. So typically, we don't just rely on one value. We want to see a confirmation PSA, and then typically if it's anything above 3, then the primary care doctor will usually initiate a referral to a urologist to determine if a biopsy is indicated. And this is also something that's an evolution now. There's another test called a prostate MRI, which is sometimes helpful before a man even has a biopsy, so that the urologist can get a better idea of the anatomy of the prostate and where there might be a potential cancer hiding out.
Yeah. John, let's talk about early detection. Was that a part of your story? Share about your diagnosis in general and how you got there and where you are now.
Yeah, this is was I detected early enough? Yep. Was I doing it for the right reasons? I mean, was it found for me doing something compliant? Not at all. So I'm going to go back and revisit your story about your husband. It's so typical male. He's not going to the doctor because he's not doing what he's supposed to do, right? Or we don't go to the dentist because we haven't been brushing our teeth and flossing. So let me catch up a little bit, get a good grade, That is so typical male. I was a virgin, a prostate virgin, a urologist, wasn't even part of my medical experiences until I was diagnosed. I was doing what men do best. We are performance seekers. We go regrow our hair, get our muscles, restore our sexual vigor, but that other stuff, we don't want to have anything to do with it. So this doctor ran that PSA test. I was at a testosterone clinic, and he ran that PSA, and it was high, pretty darn high. And he was the first one to really articulate it in a way to me that kind of got me alarmed. Prior to that, thinking back, my PSA had been kind of creeping up, but nobody really spoke to me about it in a manner that made me understand it. So men, I'm sorry to say it, we need a lot of help from doctors because we're like little boys, scared little boys, and we need doctors to really kind of do that extra effort to make us take note. So this one doctor did, and I went to your urologist, and I embarrassed myself because it was, again, my first time. I asked to see his hands. They were small, by the way, and I told him he should put them on the website, because he'd get more customers. I mean, I just made a fool of myself. Told him he should play some Barry White music or, something.
It's
but
that awkwardness. It's
yes,
an awkward conversation.
It was so, but he laughed, because I'm sure he gets that all the time, right? And honestly, I say this joke all the time, that prostate exam experience was about the quickest in and out appointment I've ever had. There was really not a big deal. In my mind, it was this horrible, gigantic hand gonna, violate me, but it was kind of a non-issue. And then, of course,
can I just say something really quickly? Don't you think this is where pop culture and movies and TV shows, they bring that kind of air to it? So when you think about it, like, I'm not going to go do that. Like, wait, what is this? And so you already have all these misconceptions about what this experience is going to be like. And why would someone just voluntarily go and sign themselves up for that?
Yeah, I mean, women have been probed, since 12, 13, 14, right? Men, you tell a guy at 40 or 45, you need to do that. It's a much different kind of mindset. And we're not very good at it. And, even like the impractical jokers, those guys that do all those jokes and they make the loser of their contest do something. They made him have a prostate exam on TV, and all the audience male members were just like, oh my God, I can't watch this, and that is the stigma of men, right? Anything in that behind us is just taboo. So we run from it. But to finish my story, he did the exam. It was quick, but concerned. Biopsy followed, and quite a bit of cancer. I think 3 of the quadrants. And from then on, it's, there's more of the story, I guess, which we'll talk about later. But so early detection was not part of my intention. I wanted to go get testosterone. And this one doctor, at that clinic, who could have just put me through the system. And by the way, I understand testosterone is a kind of feeds, or the theory is that it feeds cancer, but he really explained it well, and nobody before him had really done that. And I think doctors get kind of into this mindset: I order 1,000, of these a year. It's like ordering a cheeseburger, and they don't really dumb it down for men and really explain it in a way that we need to listen. So
thank you, Dr. Shivani. How do you get more men to be proactive with their health? How do you kind of destigmatize these misconceptions, this awkward feeling of having these types of exams? Or is it just one of those things where there's no way getting around it? You just have to do it, right?
Yeah, I mean, I think definitely people's prior experience with healthcare may color their impressions about what something is going to be like. I turned 45 last year, and I had to do my colonoscopy for the first time. And so definitely hearing about it and going through it are two different things. Hopefully through forums like this and education in the community or throughout the country can help destigmatize some of these, sort of preventative measures. And it's like the saying goes, ounce of prevention is worth a pound of cure. So I think, just sort of emphasizing that it's a lot easier to treat cancer, when it's this big as opposed to when it's that big, that type of thing.
And speaking of treatment options, can you talk about a little bit of those options? A few years ago, I saw my first proton therapy center when I was with, ironically, Texas Oncology Foundation. And it was a beautiful facility, but I had never heard of it and seen it. Now I've seen them pop all around in different states and different places. Can you talk about what the traditional treatment is, what's new on the horizon?
Yeah. So typically when men are diagnosed with prostate cancer, just to kind of back up a bit, there are kind of 3 main things that we look at. The level of the PSA, the Gleason score, or a measure of how aggressive the cancer looks like under the microscope, and then what we feel when we do the rectal exam. And so most men, because of PSA screening, are diagnosed with relatively early stage prostate cancer, and they can typically be offered surgery or radiation. A lot of men may have very non-aggressive appearing prostate cancer, and there's a third option called active surveillance, which means that they can be monitored to see if they even need treatment for cancer, which is probably a whole other discussion. When we talk about radiation, typically most facilities offer radiation, which is a daily treatment Monday through Friday for several weeks. It used to be routine that patients would be getting 8 to 9 weeks of radiation, and now we're routinely giving slightly higher doses to finish the treatment in about 4 to 5.5 weeks. Proton therapy is a form of radiation that behaves a little bit differently than photons, which is what my cancer center and most of the cancers have in the United States. Protons go inside your body a certain distance and then they stop. And so where that has a very compelling role is in children with cancer, because radiation can affect the growth of their bones and the development of their organs and so forth. For prostate cancer specifically, proton therapy does have a lower dose of radiation to the surrounding normal organs, like the bladder and the rectum. Now, how much clinical benefit that leads to is a little bit controversial. But for some of my patients, my younger prostate patients, like in their 40s and 50s, I definitely encourage them to consider proton therapy if they're willing to travel to the proton center.
For someone who's newly diagnosed, they may think like, how do I decide? How do I choose one through all this? So how do you come up with a treatment plan? How do you figure out what's best for you. And this isn't even bringing surgery into it. This is just talking about the treatment aspect of it.
Right. So obviously no one's God, no one knows what's going to happen in the future. And so really looking at all these options is really sort of a risk benefit calculation for each patient. And two patients with the exact same type of cancer may make different choices based on their own personal values and preferences. And so this is different than the old days where the doctor said, my way or the highway, or this is the treatment you're getting. Especially in the world of prostate cancer, there's a ton of choices for how patients can choose to have their cancer treated. And outcomes seem to be pretty comparable between all of them. And so then it becomes really a trade-off between, distance traveled, convenience, number of visits required. Side effects are slightly different from one treatment to the next. And so that's really what we spend a lot of time talking about in our first visit. And fortunately, with prostate cancer, a lot of times patients aren't compelled to make a decision that day or even immediately. And so I encourage them to, talk to other patients or friends that they know of who may have gone through prostate cancer treatment. There's a lot of resources online. I find some of my male patients are very reluctant to talk to others about their diagnosis, but they may know some people in church, or if they don't have anybody, we're fortunate to have a nurse navigator to help connect them with support resources, both in person and online.
So very important to have support when navigating through a cancer diagnosis, but also the survivorship phase. And so, yes, absolutely, you may not want to lean on that support, but it is truly a valuable option that is available for you. John, let's talk about your treatment plan, and what were the factors that helped you decide what was going to be the right treatment for you?
Yeah, it happened really rapidly, but when I was diagnosed, I couldn't even tell you what the prostate's function was, and after that, I queried 20 of my friends and asked them, and every one of them answered, "Hey, do you know what the prostate does?" "Oh, I know where it is." Everybody knew where it was, but nobody really knew what it did. And I'm not going to be a spoiler. You got to go look it up yourself, because I'm pretty sure most men on here don't even know. Which again, that's a reflection of the male mentality. So I had to do some research. I had to go looking into it. The way I got to Texas Oncology, by the way, Dr. Wazoo, who was also with Texas Oncology, I had a relationship with him for a non-cancerous blood condition that I would go see him every couple of months for getting therapeutic, draws. And I was amazed at this cancer center and how happy the people were all the time. It was these chemo patients, when I'd be sitting there getting therapeutic draws, they were very, very happy people. And so when I was diagnosed, I was like, this is where I'm going to go. And when I went to see him, he ordered a bone scan, and that basically is to determine if prostate cancer has spread to the bones. That's pretty commonplace, as is some of the neighboring organs. And so a couple of MRIs also. So while I was waiting to find out, because if it is, that's metastatic, if it's gone, spread to other locations, and that's basically a death sentence. If you find it while it's localized, still there, and you treat it with one of the options Dr. Shabnani mentioned, your chances of being alive in 5 years is almost 100%. But if it spreads to other locations, it's 2 out of 3 are going to be dead in 5 years. So I had this little waiting period, while he did all those MRIs and bone scans, and I researched all these options that he mentioned, because there was no option for metastatic prostate cancer. So all I had to do was hope that I was not metastatic, and research those options. And one of the ones that came up, Dr. Shabnani was talking about how you kind of get away, how it fits with your lifestyle, et cetera, et cetera. So all the kind of risk factors were similar, but I didn't want to go somewhere 5 days a week for 8 weeks, 40 times. Just didn't fit my lifestyle. And I was fortunate enough that Dr. Shabnani also had offered stereotactic body radiation therapy. It was super intense, 2 weeks, 5 sessions. So all that's condensed down, and it's very intense. And I decided that's what I'm going to do. And actually, it turned out to be a good thing, because my PSA, which was already high, had doubled within 1 month. And, I even asked Dr. Shivnani about that. I said, what, do you think this was about to go metastatic? He said, there's no way to know, but, that's a big jump. And it could have, all signs could have been pointing to that. So I'm glad in my case, we did this rapid kind of knock it out really fast thing. And so that's kind of my whole kind of treatment journey there. Hopefully that answered your question.
Thank you. And Dr. Shivnani, did you want to say anything?
Yeah, I mean, I think that's kind of a good example of how a patient can kind of think through the different options that are available to them and then pick the one that most connects with them, the one that they're most comfortable with. Because, our job as physicians is not really to, convince them to do one thing or the other. If there's evidence that they all work equally well, it's to try to find the best option, for that patient and help them make the right decision that they're going to be most comfortable with. Because once I give radiation, I can't take it back. So the last thing I want to do is treat somebody who hasn't thoroughly investigated, the other options.
Yeah, and I just, also, if anyone on here who is metastatic, there are therapies that are coming on the market constantly, there are options. And so in terms of, I think when you hear the word cancer, you do think it as a death sentence, but there's so many options that are out there. And like I said, even since I've been diagnosed with cancer, so much has changed in this time. I mean, if we look at 2019, there are new things coming on. And so if you're dealing with metastatic disease, just know that there are things out there and it may seem hopeless. And if you aren't at an emotional state where you can have someone ask on your behalf. One of the things that I also want to discuss is, let's talk about the patient-physician relationship, and not only how it impacts what decisions you have on your path towards dealing with a cancer diagnosis, but if you have a doctor that you feel like you can't communicate with, or if you have a patient that is very hard to communicate, how do you navigate those things? And so, Dr. Shivnani, we'll hear from you first.
Yeah, so I mean, we're fortunate living in a big metroplex where there's access to a lot of doctors. And so I tell patients, at the end of the day, you have to be comfortable with the doctor that's taking care of you. And if you're not, then you should find somebody that you are comfortable with. And so, fortunately, there's a lot of specialists in this area where people can go to for opinions. Obviously, it's a little bit harder in more rural locations where there may not be as easy access, but I think now with telemedicine, that's definitely been an advantage, that people can seek evaluation at cancer centers, 100, 200 miles away without having to leave their home. And so I think that definitely has helped level kind of the playing field for patients. So that's kind of how I talk to patients about that.
And John, how did you approach doctor-patient, that relationship and communication?
Well, cancer is a lot of things. It's and many of them are expletives. I could give all kinds of bad word names, but it's also a teacher. It really broke down my ego a lot. So, doctors, again, I'm going back to this point. I hate to put so much pressure on doctors, but men, we just need a lot of help, in communicating. We feel vulnerable. We don't want to admit things, and we're afraid to ask questions because we don't want people to know we don't know. And so it's hard. And I would just say there is sort of we got to do our best to educate men and kind of get them where I think women have become with breast cancer. And doctors also need some education too on how to help. I think, but Dr. Shivnani, he was, and Dr. Wazoo and some of the others in my journey really did well in communicating with me, and that really taught me how important that is. So I felt really comfortable asking questions and admitting things, and but it's maybe the second most intimate relationship you have next to your partner or spouse, and you just have to embrace that.
And speaking of communication, I just want to remind those of you who are joining us today, feel free to utilize the chat or the Q&A function to ask any questions. There are no questions that you should be ashamed of, or either just share a comment, share your experience to utilize those. I want to talk about intimacy. I think when we talk about certain cancers, there's a lot of people who feel that we have to be able to talk about sex. And whether it's the patient that brings it up or the clinician who brings it up, we need to talk about sex, like the song "Let's Talk About Sex," right? And it can be an uncomfortable conversation for many, but there are also people who are not getting treatment or who aren't being screened because they're worried of how this will affect the intimacy that is in their life. So Dr. Shivnani, can we talk a little bit about that?
Yeah. So, I mean, the reality is, any of the treatments we have for prostate cancer have some potential to affect sexual function after treatment. So we kind of get that elephant in the room and sort of talk about it openly with the first visit. I think that's one of the advantages to active surveillance approach for men who have a very favorable appearing prostate cancer is that sometimes if it can be monitored safely, then men may be more comfortable not considering or not having to consider that treatment would potentially affect their erectile function or sexual function. I think for men with more aggressive cancer, men who choose to go ahead with treatment, we do kind of give them an idea about what the chances are that they may have some decline in their sexual function after radiation, the time course that can happen with. It's not typically an immediate thing. It's something that can manifest over 2 or 3 years. And then, how we generally approach that for patients if they do notice that. And we have sort of a sexual health inventory scoring system that we have patients complete before they've started treatment, as well as afterwards, so that we have some baseline for future comparisons.
Yeah, and so John, you're muted. You can take yourself off of mute. No, just on Zoom. And if you can talk about what was that part of it, learning about the potential intimacy side effects or loss of sexual dysfunction. What was that like for you in wrapping your head around that information?
Well, first of all, even before you have cancer or somewhat aggressive cancer like I had, it's already affecting you. It's already making a difference in you. And so getting diagnosed answered a lot of questions. But the one thing I got to say is that, a cancer diagnosis, whatever kind of cancer it is a diagnosis for the entire family, especially your spouse. It's a strange disease in that sense that everybody just, is diagnosed in a way, because it's a major factor and an impactor, on lives. And so it's really important, to stay in touch with your spouse on this topic specifically, to be silent, to be quiet about it. Even though they're kind of diagnosed by proxy, just in their relationship with you and having to go through the journey, it's the communication is super important because, when you're just silent, you don't talk to one another, they don't know, that you're going to get back to normal. And they don't hear you say that you want to, it's hard for them. So we were good about communicating in my case, and I think that's super important. And, in about 6 months after, again, that very intensive radiation therapy where I think I glowed in the dark for half a year and spoke to, toilets for quite a while too. It's interesting, when I got the radiation therapy, I didn't feel anything. I was like there for 15 minutes laying there, and I was thinking, this is, I feel like I'm Emperor's New Clothes, this is a joke. And then it kind of creeps in and you start feeling the effects that we're talking about here. But it goes away, and I'm not going to give a medication name, but through that time, we communicated, and then Dr. Shivnani has now prescribed me a medication, which is a daily thing, which it works perfectly. So there are solutions to help medication, but communication is the most important part to get through that phase.
And it really is about accepting a new normal. Thank you for your comment in the chat, Dr. Shivnani. So I literally think that, sometimes you have to let go of what was once before. A lot of times we as patients think about our previous sexual selves and not looking at our new normal, that things are going to be different. What you could do previously, you may not be able to do or experience or achieve exactly the same way before. And I think it's very true that, the new normal is so hard because it is new, but for us, it's nothing normal about it. We're thinking about our pre-cancer selves and not our post-cancer selves. So it's really, really, really important for us to be able to look at that in that way. Dr. Shivnani, did you have any other comments about that?
Yeah, I mean, one thing that I'll add is that, some of these changes we see are also normal parts of aging. I try to tell my patients that, as we age, there is some decline in sexual function in a lot of people, regardless of whether or not they're diagnosed with prostate cancer. So I think expecting that your, lifestyle, physically, mentally, sexually is going to be the same, throughout your adult life is not, realistic. And so, yes, cancer treatment can certainly impact that, but I think just trying to keep it in the bigger perspective as well, and also looking at their other health issues, talking about life expectancy, why we're doing this, why it makes sense to consider treatment, is also important in that bigger picture discussion.
And I also want to bring up, if you are at a more advanced age and for some reason your physician is not bringing up your sexual health or anything like that, maybe they're looking at you and they may think you remind them of their grandma or their grandpa, and they're thinking, my grandparents are not intimate. You remind them that it is very much the human experience, and it is a very important conversation for you all to bring up. So we're just a little over the halfway point here, and I want to talk about caregivers. And while the patient is the most important, we know that caregivers, and that could be a best friend, it could be a partner, it could be anyone who is there to support you, even a coworker. What is the role of caregivers, especially for people who may be a little reluctant to already talk about what's happening to them? What's the best approach for caregivers, either anyone?
So I'll start. I would say with caregivers, we find consistently across various cancers that patients who have strong family support or caregivers tend to do better. They are sort of encouraged to stay active. They're encouraged to report side effects or things that they're experiencing during treatment, and just that reassurance, oh, this is something that's normal, or oh, let's try to address this by doing X, Y, or Z, I think is helpful, because to John's point, a lot of men specifically don't bring up things that are going on to us. And so I think that caregiver can be very helpful, if not critical, in terms of helping with that communication between the doctor and the patient.
John?
Yeah. Well, so just a little bit about the way I handled my communication. I didn't tell anybody about my cancer except my wife and my oldest daughter. My oldest daughter, because she had to drive me to, some of my appointments. I didn't tell my little kids. I didn't tell my friends. Told my brothers, but I didn't need anybody to be downtrodden and sad and wondering. I didn't need that kind of energy. So to the flip side of that, caregivers need to be strong. It's a big deal, to not be panicky and not the world's coming to an end, or what's going to happen. I mean, they need to be super strong, and that my wife was that, my oldest daughter was that. But That's super important because that energy, that thought, you got to keep it way up there.
I think it's really important for caregivers to have support too, and so for them to seek out other caregivers. There's a wonderful organization, Texas Oncology Foundation, that hosts supports and is very inclusive of caregivers. There's Emmerman Angels. They do one-on-one matching support for caregivers. November is recognized as Caregiver Awareness Month. And so it's really important for caregivers to seek out their own support too, because it is very overwhelming. We have another John that says hello to his cousin John. My question, I'm reading more and more about inflammation as a major cause of disease. And with that, there's a lot of chatter about anti-inflammatory diets. Do you believe these diets help with the prevention of cancer or any other disease? And do they also help with the healing process in addition to conventional treatments? Dr. Shivani, I'm going to assume that's for you.
Yeah, so there's been a lot of research in this area, and it is a challenging thing to study because, what type of intervention you look at, how long someone does that for, how does it play into other lifestyle factors? I think it's all interconnected, and I don't think we really completely understand the full picture yet. But in general, what I tell patients is that kind of the common sense things that you've heard of since you were probably a kid, plenty of fruits and vegetables, limiting, red meat, limiting fatty foods, limiting alcohol. It doesn't mean you have to give up those things, but just in moderation, because I think probably the unhelpful thing is doing some extreme diet for a month and then getting tired of it and then going back to one's old ways. But I think if you can make gradual changes in your diet over time, there is evidence that healthier diets and physical activity do help with prevention, but also outcomes after one has gone through cancer treatment.
And there are some great resources on the Texas Oncology Foundation's website. And Kelly, if we can put that in the chat, there's some past webinars with Nicole Hodak and a few others that really focus on nutrition. And they're really, really good. I know a lot of times you think like, I don't want to listen to another thing, and I know I sound like a super fan, is that we always have great speakers and great guests, and we make the content where it is specifically what the consumers of this information are looking for. So I really would encourage you to head over to the Texas Oncology Foundation's website, look at their resources page, and look up any of the past webinars. But there's some really great ones on nutrition that have been really good, and some great recipes as well. So don't miss those. John, have you changed your diet or anything post-cancer? I know there's some people who I don't want a candy bar, I don't want any soda, I'm not going to drink any liquor. There are other people that do things in moderation. So we have, people who go through a cancer experience and then they remove all the sugar, all the white flour, everything out of their diet. There's some people who are like, nope, I almost died, I'm going to eat whatever I want. And then there's people who are kind of in between the two. Where do you stand on it?
Yeah, so that's a great question. I actually went and asked Dr. Wazoo, partner of Dr. Shivnani's, for a nutritionist afterwards, because I think that's probably the least understood part of our health care is nutrition. I just don't think there's enough emphasis placed on that. And I don't think it has to be extreme. Like Dr. Shivnani said, you don't have to cut this out all the time, et cetera. But, just becoming better educated about what we eat and maybe balancing it out a little bit more towards fruits and veggies, et cetera. As opposed to French fries and a burger and barbecue ribs, which I love those things too. But so I definitely changed, and it definitely was an easy change. And you still get to eat some of the same things you like. It's just kind of changing the proportions and making some different decisions on some things. But I definitely did that, and it definitely helped. So that I would encourage that to become. I requested that, but I think oncologists should make that part of the whole treatment plan. Is after you finish, you need to spend 4 weeks with this nutritionist to learn and go from there. So that's what I did. So
great advice. It's, you know, one of those things, again, you know, there are all these resources, but we have to take advantage of them. And we know that there is a reluctance to do so. Dr. Shivnani, I also want to talk about healthcare disparities, because we know in certain populations, the numbers of these cancers are even larger. What do we want those who fall within certain communities to know about health disparities, their risk, and why they should get in to be seen by a doctor?
Yeah, I mean, it's a tough problem. It's a society problem. So, you know, sort of, I'm often the last doctor a patient sees in their cancer journey, but I would just encourage patients who aren't able to get in to a primary care provider for whatever reason to see if there are options, community clinics and so forth, where they can talk to somebody, whether it's a mid-level, a nurse practitioner, physician assistant, about what resources there are for cancer screening. You know, and I think it's something as a society we need to do a better job of addressing. I don't think there's going to be a one-size-fits-all approach. I know in other places I've practiced, you know, there have been prostate cancer screenings and other types of screening initiatives to try to get more people screened in the community. And so where those opportunities are available, you know, trying to highlight those and take advantage of those.
You know, my dad died of colon cancer the day before my 17th birthday, and he was my best friend. He had a history of smoking and, you know, occasional drinker. But one of the things that he wasn't proactive with his health. The reason why he got in to see a doctor was when it was too late. My mother was doing his laundry and she found some things, questioned him about it, and he had seen signs, but wasn't really addressing. Now, of course, we have screening for colon cancer and all these other things. And I think about where we've come. But, you know, growing up in South Carolina, in the culture that I grew up, religious, Black household, but very private. But I share his story because I want people to know that, you know, this doesn't have to be the outcome. And it kind of leads to a question that came up. And thank you so much for this question. What is the recommended age to have a PSA test and or prostate check if your family has a history of prostate cancer?
So in that group, I would recommend starting at age 40, and then once a year if everything is normal.
and I'll piggyback on that. I'd say 40, no matter who you are, right? You know, that PSA test is just a little vial of blood. It's like a lab test, you know, like a CBC or whatever. It's a nothing. And, you know, once a year is all you need to do it, in my opinion. I'm not clinical like Dr. Shivnani, but, you know, what's the big deal, right? So, I would piggyback on that and say, you know, if your doctor's doing any kind of lab test and you ask them to do a PSA. And then, you know, you may be told, hey, your PSA is 6 and not anything else. You need to understand that's high, you know, and I need to go see a urologist. We just have to be better educated about that. But I definitely say 40 for the whole group. You know, African Americans, I think, may be, you know, wrong on this, but I think it's twice the, you know, chance of getting prostate cancer. You know, it's the number 3 killer of men. Not because it's not curable, but because of the male ego and the way the way we are with healthcare, as you said, finding it too late. I think in Jamaica, it may be the number 1 killer of men. So, I mean, it's deadly and preventable at the same time, which is perplexing to me. And that's kind of what made me change so much, as I scratched my head about that. So, you know, once a year, a PSA test, not a big deal.
I think also what's really important is that there needs to be more education, as has already been said today. When we look at breast cancer, there was a time when people didn't talk about breast cancer, right? Where it was a taboo subject to talk about. Women didn't want to go in and get mammograms. Now we see pink ribbons everywhere.
October is pink.
I also think there's a little, people have become desensitized to it a little bit because we do see it so much. It doesn't mean that it isn't deadly. It doesn't mean that it is important, but there's a fine balance of it. But we don't see the same type for most other cancers, but especially male identified cancers. And so I think it's really important for us to continue to have spaces like this where we talk about it, give people the option to be able to share their thoughts as well. Where you start this and there's so much time, and then all of a sudden we run out of time to do it. The conversation doesn't have to stop here, but I do want to give you all just a minute or two to share your closing thoughts. So John, we'll share with you. What are your closing thoughts that you want the audience to know?
Yeah, so this journey, it made me realize that the male ego just does such a disservice to us. I didn't even know that men die 7 years sooner than women. Number one's heart disease. Number two is lung cancer. That's certainly going away with people stopping smoking and asbestos not being used in homes, et cetera. And number three is prostate cancer. And we could close that gap. We're robbing the world because, men like women, they play an important role in other people's lives. They're either a father or a son or an uncle or a grandfather or a coach or a teacher or man of faith or a physician. And 7 years, on average earlier, it's such we could avoid that if we just changed our attitudes a little bit. So all I'm saying is, we need to go to the doctor, a wellness check. I'm not sure if guys ever even do those things, but become educated and get engaged and go to the doctor, regularly, and just take care of things like blood pressure and cholesterol and, get a PSA test and get a colonoscopy, those are the best 5 pounds you ever lose, by the way, those colonoscopies. It's pretty, pretty amazing. But anyway, just get involved and don't, as far as all of our other male qualities and we're stubborn and apply that, healthcare is not the place. That's living life based on luck, and that's a losing strategy.
Thank you. Dr. Shivnani?
So this pandemic has taught us a lot, and I think one of the things in healthcare is that we're expecting a tsunami of patients coming in with cancers that could have been diagnosed several years earlier. So I don't say that as a scare tactic, but I would just encourage everyone to seek out these opportunities for prevention now, so that you or your loved one isn't part of that tsunami.
One more thing I want to say, one more statistic. This stat blows my mind. Cancer kills 10 million people a year, 10 million, and that's such a big number, and it happens every year that it's just like a piece of wallpaper. We live with it. It's like World War II going on year after year after year. It's a giant number. If COVID killed 10 million people, that would be a big worldwide, meltdown. But cancer kills 10 million every year, and like he said, it's just comes in waves, and we find it too late, and it doesn't have to be that devastating. So,
yeah, I mean, cancer is a horrible disease. I'm so grateful for what we do have. We know that there's more on the horizon, and unfortunately sometimes as patients things aren't changing as quickly as we need them to change. But I'm really appreciative to all the clinicians and researchers and everyone out there that is working hard. A funny story on Thanksgiving, I saw a notification come up on my phone. It was from some doctors who were working on something. And typically I probably wouldn't have responded, but one, I was like, go enjoy your turkey, but I felt good that they were just, even on this day, they wanted to share a thought that they had to make patients' lives better. And
yeah.
so I'm really grateful for that. I'm grateful for all the doctors. I'm grateful for all the patients like you, John, who are willing to share their experience. We learn more from each other. Dr. Shivnani, I'm grateful for you for taking this time and sharing in this way. We know that you're busy and you're doing a lot, but this speaks volumes that you're willing to share in this way. I want to thank each and every one of you who joined us and shared in this discussion. And I want to say this, whether you're watching live or on the replay, this conversation does not stop here. We encourage you to reach out to your physician. If there's a specific question that you have, ask them the question. If you can't ask them, I want you to email them. I want you to drop a note off at the office if you can't say the words out loud. But I want you to be proactive with your health. I want you to schedule your annual screenings. Because of the pandemic, annual screenings were down 90%. That means that we are going to find more cancers because people were not getting screened. So now is the time for you to do it. I just had my mammogram and I'm glad that I'm able to check that off my list. So whatever it is that you need to check off your list, make sure that you do it. There's a lot of resources out there. Find time to go on texasoncology.com, texasoncologyfoundation.org. We mentioned the webinar archives and the resource pages earlier. They cover so many topics like nutrition, like this, intimacy, caregivers, etc. Make sure that you have those resources. They're there at your fingertips. Reach out to the foundation if you can't find it or you have other questions or if there are other topics that you want us to cover. I want to thank you wholeheartedly for the foundation. On behalf of the foundation, thank you everyone for joining us today, and we'll see you for another webinar in the future. Thank you so very much.
Thank you.